Good afternoon, everybody. First of all, I'd like to thank Dr. KP for giving me this opportunity to be in this instruction course. Toric ICL is a very safe, effective, strong, durable, and reliable, predictable way of correcting astigmatism. And the versatility of indications that are there for a toric ICL makes it all the more important to have it in your surgical armamentarium. I will be dealing and telling you when and how we can use it. Basically, the preoperative indications, the preoperative measurements, and the intraoperative do's and don'ts. Toric ICL is a when I say ICL or a phakic IOL, I'm talking about a posterior chamber phakic IOL which actually goes and sits in the sulcus. So the ICL is actually a Collamer lens, which is a proprietary material to the Star Surgical company. It has a very wide range of prescriptions, like even in a myopic astigmatism, hyperopic astigmatism, even in plain astigmatism, to as less as minus 0.5 with 5.5 cylinder, plus 0.5 with 5.5 cylinder, we can still treat these kinds of astigmatism with toric ICL. And as it is already mentioned by previous speakers, yes, irregular astigmatisms are always a tough nut to crack. Can we correct it with the ICL? No. I mean, we'll have the same amount of success like in any other modality of treatment. But the quality of vision that we achieve with an ICL, because of its closeness to the nodal point and it is increased retinal image size, makes it all the more better or as a very reliable option to go ahead and use it in most situations. It sits far away behind the endothelium, so the reservation that some surgeons have that it could have an effect on the endothelial cell count is unfounded. So because of its closeness to the nodal point, like I already told you, the wow factor that we can achieve with very high astigmatisms along with myopia or hypermetropia is something that the patients are very, very happy about. Because the toric design is designed on the same platform as the other ICL. So the stability of the ICL has been proven for more than about 13 to 14 years now. So the advantage of it being in the sulcus and the shape of the ICL or the design of the ICL being very snugly fit into the sulcus makes it very predictable even in the very long run. So the reversibility of this procedure also makes it all the more attractive, because when you go ahead and treat very high astigmatisms on the cornea, the amount of tissue that you remove and the chances of ectasia that you put the patient through is taken care of when you're dealing with an ICL. So now coming to the optical zone. The optical zone in these ICLs, I mean toric ICLs, same as the dioptric range that I have showed in myopic or a hyperopic ICL. So we get an optical zone of almost about equivalent to the corneal plane, about 7.6 when you have a dioptric range up to -9. So if we can get an optical zone of as big as that, that cannot be matched when you're actually treating on the cornea. So the kind of the wideness of the optical zone makes the visual outcomes amazing for the patients when we use toric ICLs or toric phakic IOLs. Coming to indications, yes, it is said that we have to use it between 21 and 45, but we all know that we use it from as less as 18 years of age. So having an ACV of more than 3, we can actually go down to as less as 2.8 angles. We don't usually do a gonioscopy in all patients, but if you have a suspicion of the angle being low, then a gonioscopy has to be done. Previous corneal surgeries or any kind of an intraocular surgery, we have to tread carefully. Contraindication, yes, small anterior chamber depth and narrow angles may be the most important contraindication that we have to keep in mind. And in patients who are closing towards 40, 35 to 40, also look very closely for nuclear sclerosis changes. And if they do have that, then ICL is not an advisable option. There are other off-label indications like it's already been discussed, post-refractive surgery residual astigmatisms, post-cataract surgery residual astigmatisms, and post-keratoplasty residual astigmatisms. In all this, toric ICL can be a good choice. And in the pre-operative assessment, like I told you, there are a few important things that I want to tell you. First is the refraction. The refraction or the subjective refraction is what the power of the ICL is based upon. So doing a very good subjective refraction, but at the same time also doing a topography to know that the subject at what level the astigmatism is. Dr. Rohit Shetty has elucidated very clearly about those points, so I won't be treading there. And then the other measurements that we have to be very clear about are these three things: the anterior chamber depth, the wide to wide diameter in that order. Anterior chamber depth, wide to wide diameter, IC angle, AC depth. Then the axial length. The axial length is very necessary if at all you have a complication intraoperatively and you go ahead and breach the anterior capsule. You should have a IOL power ready in such situations. Coming to refraction, like I already told, a contact lens refraction can be done, but most of us don't do it. But cycloplegic refraction. Coming to anterior chamber depth,
admin, please mute all other people. Admin, please mute all other people.
The ACD is calculated from the endothelium to the anterior capsule and not from the epithelium. Also, always make sure if you're using any equipment like the IOL master or the ultrasound, you have to negate the pachymetry values to get the actual ACD value. Coming to the overall anterior chamber, yes, when we check the anterior chamber depth, we're actually checking at the center of the pupil. But then the peripheral anterior chamber could be narrow. In such cases, when you do, and it's always better that we do an anterior segment OCT and know that. And if that is the case, do a gonioscopy, rule out any kind of an angle pathology before going in and choosing an toric ICL. Wide to wide diameter, the most determinant fact for success of an ICL surgery is the wide to wide diameter. So sizing it well is very important, especially in toric ICLs. If the toric ICL rotates, if you have a wrong wide to wide diameter, the toric ICL is bound to rotate, and you will have erroneous outcomes and very unhappy patients. How do you measure the wide to wide? Take the patient to the OT, make the patient lie down under the microscope, put a speculum and use a digital caliper. When you use a digital caliper, always make sure that you're checking from mid-limbus to mid-limbus so that you get a very accurate value of the wide to wide. This actually, there is a correction factor given in the software which actually calculates for the wide to wide and makes adjustments for the sulcus to sulcus. But the best way to measure the sulcus to sulcus would be doing an ultrasound biomicroscopy so that there are no surprises. So yes, IOL master and OBSCAN does give you a very, does give you a wide to wide, but then there are some correction factors that you have to keep in mind. In an IOL master actually shows an excessive of 0.34 compared to the caliper, and about 0.5 excess compared to the OBSCAN. So always keep this in mind because optical biometries are getting more and more common these days in practice. So you will be tempted to use your optical biometer, but tread carefully and know that there are some correction factors that you need to use. If you do not size your ICL well, one, the toric ICL will rotate and you'll get erroneous result. Number two, you can end up with cataract or glaucoma. A low volt will cause a glaucoma and a low volt will cause a cataract and a high volt will cause a glaucoma. So sizing it is extremely important. This is how a toric ICL looks inside the eye and outside. So the toric ICL design is exactly the same as in a spherical ICL. The cylindrical, the toricity is actually on the anterior surface, and always the toricity is a positive notation and it's a plus cylinder and not a minus cylinder. So YAG PIs are not needed in most of the myopic ICLs. It is only needed in hyperopic ICLs. So because of the centrifugal technology. So the lens alignment marks, Dr. KP has very, very clearly told us how we go ahead and do toric IOLs. So this is no different from that. You actually make a reference mark on the cornea of 0, 90 and 180, and then you know what axis the ICL needs to be placed. The ICL, the axis on which the ICL needs to be placed is already mentioned in the printout, and based on that you make the intraoperative toric marks, and you align the toric ICL in that particular axis. So always remember that if the patient's plus cylinder axis is at 90, the lens must be aligned at 90-degree meridian. But there will be a clockwise or an anti-clockwise movement of up to about 20 degrees. So the rotation that you need to do is never more than 20 degrees. So clockwise or counterclockwise, it works well for both eyes. So remember, it doesn't change. This is a photograph of an ICL which has been aligned at 5-degree counterclockwise position in a left eye. Okay. So this is the implantation diagram. So the implantation orientation diagram has to be kept or stuck on at the OT table so that you don't go wrong when you're rotating the IOL, because it's mentioned clockwise and counterclockwise. So this is, like I said, I've already mentioned this. There's no significant ICL rotations that have been studied. So only about in 210 eyes, there's only about 0.5 degree of a misalignment. So the misalignment is extremely low. Piggyback IOLs for piggyback toric ICLs for refractive surprise, astigmatic refractive surprise in cataract surgery has also been proven, but it is not a on-label indication, it's an off-label indication. But like Dr. Sunil has already told us, the calculation method is exactly the same as what you do in a virgin eye, but and the surgery is much more easier because the anterior chamber depth is usually more in a pseudophakic eye as compared to a phakic eye. So in conclusion, toric ICL is an effective way to correct astigmatism. High cylindrical errors, I would always prefer to do a phakic IOL platform rather than a corneal refractive surgery. And a subjective refraction in white to white is extremely important. Thank you. And